Good day, all. First, I want to thank you for the wonderful job you're doing in the community. But I don't want to just thank you for the great job you're doing in the community. I want to thank you for the great job you're doing for yourself and for each other. You all have consistently worn the proper PPE. The reason why I know that is I have the ability to look at the statistical numbers in relation to the exposures we're having, and they remain consistently low. To that end, I want to thank you, and I want to continuously thank you for doing that. I want you to stay vigilant and make sure we continuously wear the proper PPE. That is, when you go out, you wear goggles, mask, and gloves. When you have direct exposure where you have possible aerosol spray from the patient, you wear goggle, mask, gloves, and then you wear a gown. So I want to thank you for the wonderful job you're doing. But there are a few things I do want to point out. We got several questions, and although assistant chiefs, deputy chiefs, and other members of the organization are going to answer it on the video, I kind of want to speak about a few of them. One of the concerns that people had was us bringing in third-party ambulances to help us and augment the system. We're trying to think ahead to make sure that we're prepared for whatever happens during this episode. In fact, I'd argue that it would be negligent of the organization not to have forethought in this area, as we look and see that New York literally has rows of ambulances going up to the Northeast specifically to augment their services. Consequently, we thought ahead of time and we began working on contracts. Some contracts actually that we already had in place, our relationships rather that we already had in place based on what happened during Snowmageddon. So what we did was we went ahead and boosted those and recreated contracts with those organizations. It's not to neglect our members, but it's to augment and help our members to help the community. So that was one issue I did want to reach out to you all and speak about. Another thing that I wanted to talk to you all about is the use of PPE. As I spoke about earlier, we all are using PPE very well, but I want to make sure that we use the PPE consistently, appropriately, and not overuse it, because we do have a good supply, but we don't have an unlimited supply. So we want people to be very considerate and very thoughtful about use of PPE. The last thing I wanted to talk about was smoke alarm installations. Now, we still have people calling 311 asking for smoke alarms. And I have to tell you, I have to be very frank with you about this. I don't want to walk away from that. It's very important for us, if someone calls 311 and asks for a smoke alarm, that we actually go out there and install. To that end, I'd like for you all to go out there. We're going to have 311 to speak to the citizen and tell them that you are going to observe 6 feet. So I want you to be very respectful when you talk to the citizens and in the community and tell them that you've got to observe 6 feet. Per direction of your supervisors, per direction of the city, and also for you and your members' health. During that episode, be very polite, but wear gloves, goggles, and masks during that episode. You are well protected. As I think Assistant Chief Surveyor is going to point out, you don't need a signature now. All you have to do is go in, install, and come out. I do not want to be in the position where someone has called 311. And I'm not talking about physically in a position, I'm talking about emotionally in a position where someone has called 311 and we did not go out there and install a smoke alarm, and something happens at that house and we lose family members, we lose grandparents, more importantly, we lose a bunch of children. To that end, we're in the fire service and EMS business, not just one or the other, we're in both. Again, I want to thank you for everything you do in this community. And I want to point out our motto again. We take pride in protecting people. But always remember, the people are not just the community, it's you as well. I need you to take care of yourself and each other. Thank you for everything you do.
Hi, I am Assistant Chief Charles Savella, Assistant Chief of Operations for the Baltimore City Fire Department, here to answer your questions. Currently, OEM, Office of Emergency Management, is working on developing 4 alternative sites that could be used for either testing or overflow of the hospital as is required. Pimlico is definitely one of the sites we're using. We've also just received approval to use M&T Bank Stadium, which we'll be putting that in place shortly. And we have 2 other sites that we have already identified, but it is in the early stages of our planning So I'm not ready to put out where those places are at this time. The fire department has an emergency callback MOP 613, that we use to put resources, whether they be personnel and activation of apparatus, in service if we need to. If we get to that point, we will follow that MOP and we will put those resources in service as needed. I am currently checking with our staffing as well as our call volume on a daily basis. And if we get to that point, I will then activate that MOP and we will put the emergency callback into place. MOP 807 addresses mass casualty incidents. This is a template that we follow. This is what we start out with. Once we put it in place, the incident commander will make the determinations on what resources and any strategical or tactical needs that may be needed. He will make those decisions and we will expand out from there as required. No, I do not feel that reducing our medic units by 3, especially in the peak hours, would be beneficial. We will keep staffing as we have with the medic units. If we get to a point where we need to put other units in service, we will take that opportunity. We will use the reserve callback policy and we will place the units and the resources in service as needed. I'm going to be putting out an operations memo which will eliminate the need for our members to get the signature on the 311 smoke detector installation form. This way, this will eliminate any need for contact with the occupant of the house, but yet it still provides the emergency services and the fire safety aspect that is part of our job that we still must do so that our citizens stay safe.
Hi, I'm James Matz. I'm the Acting Deputy Chief of the Emergency Medical Services. I'm here to just give my weekly update from the EMS Division. I think the first thing we need to start with today is to tell everyone, thank you for doing the job that you're doing. Thank you for the Baltimore City Fire Department stepping up to the plate every day like we have done in the past. We step up to every challenge that's been brought up for us, whether it was the riots, whether it's special events. Just keep what you're doing. I would recommend that everybody take their time and try to unplug from all this COVID-19 craziness. I've actually catch myself, you can't get on the TV or you can't listen to the news or the radio without hearing about COVID. Please unplug, enjoy your time with your family. I also want to tell you that every process and procedure that we're putting in place is to make your job easier, because when we go forward, it's going to be a marathon, not a sprint. The answer to that question is no. Homeless people that live on a street are not considered immunocompromised. So what are we doing to try to reduce the load of our low acuity call load? Actually, we've done 2 programs. One just started Tuesday this past week, and the other program is going to begin on Monday, April the 6th. The first program is a viral syndrome pandemic triage protocol. That's the protocol that we started on Tuesday. MIMS provided, in response to the COVID-19 pandemic, a series of ways what people that are complaining of the viral syndrome, if they fall within certain parameters, they can be left at home safely. The parameters are they have to be between the ages of 2 and 55, and they have to have 2 of the following 4 symptoms. The 4 symptoms are going to be fever, cough, body aches, or sore throat. There also can be no history of immunosuppression or immunosuppression therapy. That's like a cancer patient or somebody that's been in a transplant. They also can have no history of diabetes, heart disease, or COPD, or lung disease. Finally, their vital signs have to be within normal limits. They have to be able to ambulate or walk, and they have to agree to stay at home. If they do agree to stay at home, you're going to leave behind instructions and let them know that somebody from the EMS division will call them 24 hours later to make sure that they're doing well, that there's no problems. If there's additional problems, we'll address them from there. Also remember that this protocol can be rescinded at any time. Please remember it's only to be used for the viral syndrome pandemic protocol. The other program that we're working on is the telephone triage line. And basically what the telephone triage line is, we're trying to get appropriate use of the 911 system for our low acuity calls. That's going to be for the alpha and the omega calls. Basically a medical professional, which is going to be either a paramedic, a seasoned paramedic, and one of our nurse paramedics are going to go ahead and they're going to try to weed their way through the alpha calls and see if we cannot help keep these people at home. The options that we have to date for us to be able to do through the medical triage line is either to have the people stay home and give them some resources that they can use at home, or we're going to have to send an advanced life support unit or a basic life support unit. The telephone triage line is going to be located in the FCC and the Communications Center 7 days a week. We actually did some D3, which is data-driven decision making. What we did is we took the call determinants to look for the most common call determinant that's low acuity, and that's the 26 card, which is a 6 card. What we did is we went and analyzed how often do those calls come in and are they the most frequent. They actually come in most frequently between the hours of 7 a.m. and 11 or 12 o'clock at night. Because of that, we decided we're going to operate 7 days a week. We're going to work on 2 shifts from 7 to 3 and 3 to 11 as long as manning is available for it. They're going to once again be screening those low acuity alpha and omega call determinants. They actually had to develop a series of protocols using the Clearview protocol system. The medical directors actually went and had to approve all of those protocols. I told you about the options. They're going to be clearly documented using established forms as well as the elite system. We're going to have 100% QA with this program. They're going to have a 24-hour call. They're going to verify that these patients are still doing okay at home. We're also going to be checking the regional CRISP system to make sure they didn't utilize another transport to the hospital. Finally, future directions. As I said earlier, the only options at this time are to handle it through the nurse triage line or dispatch an advanced life support or a basic life support ambulance. What we're looking at in about 4 to 6 weeks out is the telemedicine program. We're going to have telemedicine. They're going to be able to link with a physician, probably using like a Zoom type, using our tablets to be able to talk to a physician and try to leave the patient at home. And then finally, we're looking at leveraging some of the mobile integrated healthcare programs and having our MAH treat and release card go to somebody's home, treat them there, and leave them and release them. They're going to be seen by a physician or a nurse practitioner, and hopefully that takes care of that. So the department is actively working with commercial service for our anticipated increase in call volume. It's going to be a commercial surge contract. Basically, we were told by the state of Maryland to anticipate a doubling of our call volume. Actually, the bottom is they're talking it's going to drop out roughly in the next 10 to 14 days. What we did is we reached out, tried to use things mathematically and figure out what exactly we needed. Basically, the commercial service is going to provide assistance to us to supplement our responses. They're not there to replace us. They're there to help us with our low acuity responses, which are primarily going to be directed at our alpha and our bravo responses. Basically, what we did is we tried to leverage the units in scale in their response. The initial response is going to be 8 units. And then if it still gets worse and our call volume continues to increase, we're going to scale up to 16 units. And then in the worst case scenario, we'll scale up to 24 units. They're going to be running 7 days a week, again, using the hours, 7 to 3, 3 to 11 during our primary, I guess our peak unit hours, you want to say. The base of operation is going to be primarily the public safety training facility. They're going to report there each day, get their briefing, and then they're going to report to the 4 quadrants of the city. They're basically going to be hospital-based. The 4 quadrants are going to be Sinai 210 for Northwest. They're going to be at Good Samaritan Hospital 226 for Northeast. They're going to be at 204 Hopkins for Southeast and University of Maryland for our Southwest corner. There's been an extensive amount of training that's been developed by the EMS Training Division. They have to bring the commercial service up to speed with our operational policies, the logistics, safety, accountability, PPE, and our COVID-19 operational procedures. We did bring in the incident management team, and they're going to have a daily incident action plan to work with this program. Interoperability has also been addressed. There's obviously a comms plan. They're going to have a dedicated dispatcher using an alternate channel. They're going to be issued 1 fire department radio as well as an MDT, a mobile data terminal, so that they can be tapped into available calls. They're also going to be using the Elite platform just like we do every day. EMS training is going to be the point of contact. If you have to call there, you can obviously use a number for training, which is 410-396-1005. Remember, this is temporary. It's going to be terminated as soon as the emergency abates and we can go back to normal operations. I would like to remind everybody as well to protect yourself, protect your family, and protect your community.
I wanted to review today the new Operations Memo addendum regarding patient care reporting and documentation procedures. With the increase in cases of positive cases of COVID, the hospitals will notify me if we transport a positive patient. And for the exposure investigation process, this new documentation procedure will make it easier and streamlined because we're going to start to get an increase in investigations. Basically, all fire and EMS units are to document in the narrative section of their patient care report the name, last name of the member that entered, and any member that entered, the level of PPE that was worn. So if you wore gloves, N95, goggles, if you wore a gown, you're going to note that. The contact that you had with the patient. So if you lifted the patient, if you started an IV on the patient, or if you just stood back outside of the 6-foot radius or stood in the other room with the patient. Your proximity to the patient. So if you were in close contact, you're going to note that on your report. And the amount of time that you were in close proximity. So if you were waiting for 2 minutes, if you were there an extended period of time, 5 minutes or more. And if you were present for any aerosol generating procedures. So if the patient was bagged, or if you were doing a nebulized treatment and you were present, you need to make a notation of that. Also need to have documentation of team entry. So if it's a suppression company with 4 members, if 2 members went in, the 2 members that went out, I need that documented. So if the PO stayed out in the pumper, make a documentation of that. If the officer in charge didn't enter the building, I need to have that documented as well. Also, if there's a response where on the MDT you pressed on scene, but you actually didn't enter, maybe the medic got there first and canceled you, I just need you to type in the narrative section that on scene, but we did not enter the building, canceled by the medic. This will streamline everything. That way, instead of calling 7 people who may have been involved in the exposure, I can look through the narrative, determine who was involved in the call, who had what contact, and then I'm just going to call you and tell you that you were involved in a transport with a positive patient, and we'll go from there. It's difficult to track down 7 people and interview all 7 people and ask them what level of PPE, what type of contact they had. It's very time consuming, especially if we start going from 2 to 3 positive transports a day up to 20 or 50 potentially. So that's the importance of this. This should be uploaded at the end of every shift so that I can access it on your days off. I can just pull up the elite tickets and review it from there. The company officer will be responsible, or the supervising paramedic will be responsible that this gets documented. And this was effective immediately yesterday, April the 2nd.
Currently, there's not enough data to understand the details of extended aerosolization. Virus infectivity is also contingent upon the number of viral particles and contact with mucous membranes. Whether or not the virus can spread from clothes to other people is also a matter of debate. If infection spread up to 27 feet was possible, it is likely that we would be seeing much higher rates of infectivity. The infection prevention policies are designed to do the most good for the great amount of people. Recommendations for gowns may change, but the department relies on the recommendations of the CDC, MEMS, and other engaged agencies in order to inform practice. According to Dr. Ben Larner, he does agree that the issue of gowns deserves further consideration. With that being said, just because a virus particle can be suspended in the air does not mean that it will result in a serious infectivity. There will be some additional guidance about the use of masks coming out pretty soon, and that also has the potential to change in current practice.